So we are live.
Okay, good evening, everyone.
Yeah.
I, on behalf of Center for Sight, welcome you all to this lovely program, very educative, which we termed as Coffee at Center for Sight. Although physical coffee is not available now, but coffee times is definitely there. So you see, COVID has changed a lot of things. The way we practice, a lot of things have changed. But what I look is always positive side of everything. So one thing which has happened is academics level has changed, and the way we interact, the way we do all these scientific programs. So webinar may be the future also. It's not that only during COVID times. So we thought that Coffee at Center for Sight, which we used to do only at Southern Enclave, why not take it to all the centers and virtually national level now. And based on this, I had a long meeting and chat with Dr. Ritika, and we thought we'll evolve a common minimum kind of program, which will have clinical talks, journal, and quiz competition. And this was her idea, so we thought we will, and each of these talks, because we have so many centers all across zones of India, we thought let us make it competitive and then have a chairman's trophy for the best center also. So we will have award for best presentation, and mind you, all these talks are being judged for best presentation, best talk, and best quiz master also. And overall, out of the 6 episodes which we'll do till another December or so, then the best one will get the chairman's trophy, and this will be a running trophy, which annually will rotate. So these are the 6 zones which we thought can be started as of now. So Telangana we have already done. So today is the turn of Uttar Pradesh. Then in September we'll go east. Then we'll come to Mukesh in Rajasthan. Then MP, Gujarat, Pradeep Vyas and Rupal will help us. And then finally NCR. So fortunately, Center for Sight has its own Zoom platform, and you saw Kuldeep's voice and Sunil also there. They always help us in coordinating all these academic activities. And Tulika Chauhan, very, very dynamic, helpful for coordinating. I know she troubles you quite a bit, but I think that is required for getting all this scientific information also. And Ritika is me and always available for any help if anybody requires. So 3 basic aims were there. One is to have academic vibrancy in Center for Sight, because Center for Sight is known for, academics also, apart from rendering very good, honest clinical services. And second, which I thought was to break the monotony. And third, very important, like a lot of faces I'm seeing now for the first time, so to see your colleagues, what they are doing. So this gives an opportunity to know what work they are doing. Plus, whenever you see patients, you see with that angle, is there something rare in this patient, something unusual? Let me document. Because I wanted that everybody should document. Now we have, cameras available virtually everywhere, or even mobile cameras. Sometimes I take pictures from mobile. So since we can document and then maybe present. And this, because now it has gone national, it will provide opportunity for everyone to document. And in any case, if any one of you has any ideas, suggestions, they're most welcome. So we have done, previously more than 31 episodes now, and these are small, pamphlets which we designed. So I put them in a circle, and just for the sake of showing here, I put this here. And we also bring out coffee times. In fact, I requested all the Telangana presenters to send their soft copies, so that we can print these coffee times also. And I also publish small coffee CFS snippets, so that let the whole world know in a brief form what we are doing. So these are some glimpses of coffee times. So I'm very happy we started in a very big way, and the inaugural team of Telangana did a wonderful job. Congratulations to all these people who were behind the show, right from Ajit Babu, Santosh, Rashmin, and the anchor. She played a very great role, and all the presenters are shown here. So this is the program for today. This I've labeled here as CCFS UP chapter, and we'll have Prakhyat soon to take us through, because he is the MC for us today. He will run the entire show. And this is the brief program listed here. I'll not go into details of all this, but I'll just start a motivational small, because since it is coffee, so I picked up one small movie on coffee.
One day, a group of friends, very successful in their careers, got together to visit their old university professor. After a while, the conversation turned into complaints, all about stress and work and life. The professor, noticing the grumbles, asked if his guest would like a cup of coffee.
So he wanted coffee.
They agreed, and the professor went to the kitchen and returned with a large pot of coffee and a variety of cups: porcelain, glass, crystal, and some plain looking. Some expensive and some exquisite. He told them to help yourself to the coffee. When all of the students had a cup of coffee in hand, the professor said, "If you noticed, all the nice-looking expensive cups were taken out, leaving behind the plain and cheap ones. While it is normal for you to want only the best for yourselves, that is the source of your problems and stress. Be assured that the cup itself adds no quality to the coffee. In most cases, it's just more expensive, and in some cases, even hides what we drink. What all of you really wanted was coffee, not the cup. But you consciously went for the best cups and then began fighting each other over the cups. Consider this, guys. Life is the coffee.
Life is coffee.
The jobs, money, position in society are the cups. They are just tools to hold and contain life. And the type of cup we have does not define nor change the quality of life we live. And by concentrating only on the cup, we fail to enjoy the coffee. The happiest people don't necessarily have the best of everything. They make the best of everything. So live simply, love generously, speak kindly, and care deeply. Enjoy your coffee.
So the moral of the story is linked to coffee. So I thought, I know a lot of people may have already seen this, but I thought it's still worth sharing. So live simply. These are the morals here. Speak kindly and care deeply. Love generously. Enjoy your coffee and be happy. So with this, I hand over to Dr. Prakhyat Roop, the young, upcoming, about to be senior resident at RP Center now. He will be the master of ceremonies for us. So over to you, Prakhyat. I'll stop share now.
Thank you. Thank you for the introduction, Dr. Lalit. And I welcome everyone once again to this second chapter of Coffee with CFS. Our Uttar Pradesh team has lined up an interesting and clinically relevant session for you today. And I'll be introducing the speakers just before their talks. And after each talk, we shall have an open discussion with the panel. Without taking any further time, let me introduce you our first speaker, Dr. Romi Singh. Dr. Romi is a robust cataract surgeon, having done more than 10,000 cataract surgeries and has a special interest in complicated cataracts. She did her DNB from Drashti Netralaya, Gujarat, and she is the second fellow of the Ocular Trauma Society of India. Considering that there are a lot of post-traumatic eyes that remain neglected in our society, she has decided today to present a traumatologist's approach towards traumatic cataracts. Over to you, Dr. Romi. You can start your screen share.
Yes, Romy, we can see your screen. You can start.
Dr. Romi, we can't hear you. I think you're muted.
रोमी स्लाइड्स दिख रही हैं बट आवाज नहीं आ रही. Kuldeep, can you unmute her? Or? Sunil?
She is unmuted. Dr. Romi, can you speak? Can you remove your headphones?
हाँ अब आ रही है. अभी बोलो. Just maximize her.
Is it visible?
Yes, yes. Audible also.
All good, all good.
Okay, I'm starting. So, good evening, everybody. I'm presenting a traumatologist approach to a case of traumatic cataract post-penetrating trauma. So, Caesar Ferrellini described ocular traumatology as a pop eye, that is pole to pole of the eyeball. Thus, ocular traumatologist is one who is trying to identify an explanation for everything he does. The belief that because that's how it always has been done isn't sufficient for him. Traumatic cataract remains an important cause of visual impairment and physical as well as vocational disability in spite of recent diagnostic and therapeutic advances. It occurs secondary to open or closed globe injury. Tiwari and Krishnan reported penetrating trauma by stick as the commonest agent for injury to eye. So, why we need to discuss it? So in trauma patients, there are a number of general guiding principles, but very few specific ready to apply instructions. The success rate of the cases are nowhere comparable, and it involves incomparably greater effort. A worried patient who is about to lose vision, a longer counseling hours, unreasonable expectation of functional recovery, and the greatest is the physician-patient relationship. So there is no any standard classification given for traumatic cataract. So we have classified it depending on the morphology of traumatic cataract. The cataracts due to blunt trauma are like total cataract, membranous cataract, rosette cataract, or cataract associated with injuries like jonular dialysis, capsular rupture, iododialysis, etc. The other due to open globe injuries mainly involving penetrating and perforating trauma are white soft fluffy cataract with anterior or posterior tear, and globe rupture with or without hyphema, and cataracts involving intraventricular IOFP. So the pathophysiology of traumatic cataract is believed to involve direct rupture of capsule or coupe or countercoupe and equatorial expansion due to hydraulic forces. It is often associated with corneoscleral laceration, hyphema, angle recession, iris tear or dialysis, or vitreous hemorrhage. So the patient is a 9-year-old girl who presented in the OPD with a history of injury in left eye with end of hair band 4 hours ago. On examination, the visual acuity was found to be hand movement. There was a penetrating injury with iris plugging to the wound. There was anterior capsular rupture with cataractous changes, and the fundus was not visible. So how to proceed? In this case, we should stick to all the standards that are available to us. So first one is a proper data entry that should be done using World Eye Injury Registry that is given by International Society of Ocular Trauma. Then the grading of the severity of trauma should be done. It should be done via using open globe injury classification that includes type of injury, grade, pupillary reaction, and zones of injury. Then we should assess the prognosis of visual recovery using ocular trauma score. In my case, the ocular trauma score suggests that it is 3. OTS score is 3, and I have only 41% of getting the vision of better than 20/40 in this patient. So now comes the counseling part. We have to stick to the point that visual outcome is unpredictable in these cases, because The methods to evaluate the visual outcome in eyes managed for traumatic cataract and senile cataract are similar, but the damage to other ocular tissues owing to trauma may comprise the visual gain in eyes treated surgically for traumatic cataract. Hence, the success rate differ. Then consent is very important for these procedures, especially the consent for the eye with trauma repair should be taken for medical legal importance. Then we have to make a decision whether we are going to manage the case in a single step or a multi-step procedure. In this case, I've undergone the primary multi-step procedure and done primary corneal wound repair under short GA. Now, after repairing, we have to choose the surgical technique that should be individualized on the basis of the case. The surgical technique was selected according to the morphology and the condition of the tissue. That's why we have classified it according to the morphology. Since there is anterior capsular rupture with soft fluffy cataract in my case, so after the control of inflammation with oral and topical steroids, antibiotics along with cycloplegics, when we have achieved adequate corneal clarity, we calculate appropriate IL power and examine posterior segment with B-scan. We have planned bimanual irrigation aspiration within the bag IL implantation under GA. So I am presenting a small clip of surgical procedures performed. Is the video visible?
Yes.
So since there is anterior capsular rupture with soft fluffy white cataract, so capsular staining is an important step. It should be taken into consideration that pediatric capsule is more elastic than adults and require increased force before tearing begins. Therefore, an adequate size capsular excess initiated at the site of capsular tear or at the greatest zonular stability should be done. Hydrodissection should be generous to avoid stress on zonules during lens extraction. An anterior approach is best for the traumatic cataract unless there is lens dislocation or capsular rupture with significant lens material incarcerated in the vitreous. Then posterior pars plana approach should be taken. Corneal sutures should be removed after titrating the wound integrity. Only after phagoemulsification or cataract extraction has been done. If required, we can leave sutures to remove them post-operatively. IL should be placed cautiously, taking into consideration to not to extend any capsular tear further. So it should be gentle. Now coming back, next step is strict follow-up schedule. This should be followed again by the follow-up injury form that is given by International Society of Trauma. Re-examination should be done after 24 hours, third day, 1 week, 2 weeks, and 6 weeks for refractive correction. Long-term follow-up should be done monthly for 3 months and every month 3 months for 1 year. So this is the post-op result. After 1 week post-op, the uncorrected visual acuity was 6.9, and a post-op 1 month, the uncorrected visual acuity was surprisingly 6.6 part because I have not done any posterior capsular excess in this patient. So what are the complications of trauma repair and cataract surgery? It includes corneal decompensation, hemorrhage, glaucoma, CME, retinal tear or detachment, infection, sympathetic ophthalmia. The sequelae may be endophthalmitis, corneal scarring, pars, anterior chamber membrane, glaucoma, CME, epiretinal membrane, and in pediatric patients, especially amblyopia and strabismus. So, what are the queries and doubts? The general approach of ophthalmologist is when and how to repair, but a traumatologist approach is what does it take to fully rehabilitate this injured eye. The general approach is watertight closure of the corneal wound and cataract surgery with an IOL implantation. But a traumatologist approach is to restore the anatomy to as normal as possible and functional oriented surgical approach. He also considered additional pathologies like hyphema, iris laceration, etc., and keep a realistic risk of vitreous hemorrhage, retinal break. He also reasonably think of that can happen in the future, like retinal detachment or PVR. Regarding cataract surgery, he takes in consideration the control of inflammation, appropriate calculation of IOL power, so that's why the two-step procedure is chosen. Posterior segment evaluation via 2D, 20D or B scan, and correct technique of cataract extraction. Special notes for the pediatric, everybody know that high risk of amblyopia is there, and intraocular inflammation is very common, and there is strong vitreoretinal adhesion also. Thus, a traumatologist determine the best strategy, that is the numbers, scope, and timing of intervention, and contemplates the fine details of the surgical tactics like number and introduction, sequence of the corneal sutures, their type, method of cataract extraction, type and site of IOL placement, etc. So this is my happy patients. Thank you, everybody.
Thank you, Romy, for very nice presentation as well as documentation. Only thing what was surprising to me, the introduction of the word traumatologist. I am not aware that any person like traumatologist exists. All of us are ophthalmologists, and we do for the best interest of the patient. But you are lucky, patient is lucky that relatively a simpler, IEA kind of procedure gave the best 6x6 to the patient. But trauma, as you rightly said, that can have myriads of presentation. It could be for no fault of surgeon, it could be a worse case, and there could be manifestations elsewhere, and no single prognosis can be given. But everything else was very good, and it was, to me, it was quite amusing that traumatologist ways different than the others. I personally think the approach of everybody should be in the best interest of patient. Everybody, whether it is Romy operating or Ajit Babu operating or Prakhyat operating, it has to be in the best interest of patient. It's not that traumatologist will approach in the best way and others may not. So that's okay, perfect, to make the presentation more interesting.
So it's not exclusion, sir.
Right.
It's just we should think like a trauma case in a different way. Everybody should follow this approach.
Yeah, correct.
So this term is included in the book by Dr. Ferris Kund. So that's why I have included it here.
Very nice. So let me have the reactions from Mukesh or other anterior segment people. Lalit Mohan is there. So many people are there. Yes, Mukesh. Muted.
Yeah, I agree with you, sir. I think the case should be approached by general ophthalmologist also in the same manner as traumatologist, as Dr. Romy is suggesting. I have only one small deviation from the way Dr. Romy suggested the management. She said that a generous hydrodissection was done and should be done. They were lucky. I think there was no PC rent in this particular case. We presume all case of penetrating injury as having PC rent, and a generous hydrodissection is avoided in these cases because then you may land up having lens matter inside the vitreous, and then you may need to do a generous vitrectomy also along with cataract surgery. Otherwise, I think it was very nicely managed, and all other points were very valid.
Any other comment by, say, Roop or Lalit Mohan? Yes, the word general.
I have one, Lalit.
Yeah. Yes, Ajit Babu.
Can I say something? Yeah. During the intraoperative period, the release of pupil should be taken care. In her case, if she sees the post-operative, there are some adhesions which are there. If she want to follow the fundus for long term, it will be very, very difficult with posterior synechia and all. Second point, I want to make it clear that in trauma, you should not give a very clear prognosis till 3 to 6 months, because trauma can evolve over time. So she's lucky that it stabilized early, but it can evolve in 3 to 6 months time to traction development and then secondary retinal detachment or vitreous fibrosis, and there can be a thick posterior hyaloidal proliferation. All these things should be kept in mind.
Yeah, I agree.
So, time to time, the patient should be evaluated and then give the prognosis time to time rather than giving it one go.
I'm sure that Romi must have done that, because guarded all trauma patients, like Mukesh was also saying, you have to have guarded prognosis, because trauma is not one time.
That's what
It can
follow-up.
have manifestations. Duke Elder says even 40 years after the injury also.
Yeah. It's very long
That's why
term.
follow-up schedule is very important. It should be strict and importantly told to the patient that you have to come to visit for your whole life.
Thank you, Ajit, for making a very relevant point. Any other comment by anybody, or else we move on?
So I think that was a very lucid discussion. We'll move on to our next speaker, and if there are any questions, we can come back after the next talk. Our next speaker is Dr. Mayank Mahajan, again from CFS Agra. He's a young and enthusiastic surgeon who has done his MS from IGGMC Shimla, and he's a fellow from LVPI Hyderabad in cataract and refractive surgery. He believes that in clinical practice, one has to always keep pushing the limits of one's capabilities of handling more and more complex cases and delivering consistent results with them. So with this presentation, he aims to demonstrate that even the most poor prognostic cataracts can be managed safely at any eye clinic. So let's listen in to Dr. Mayank now. Over to you, sir.
Right.
And you can share. Yeah, okay.
Am I audible?
Yes,
Yeah,
you
yeah.
are audible.
Yes.
Right. I'll just do it full screen. Right. Is the slide visible?
Yes, everything is fine.
Yes.
Right. So good evening, everyone. Thank you, Prakhya, for this lovely introduction. So I'll start with this image. And as I had given this topic to my talk, this tagline, that don't limit your challenges, challenge your limits. What we see is a person who is jumping from one cliff to the other. We don't know whether he'll be able to make it or not. But yes, if he knows he can jump that distance, if he knows whether the wind is favoring him or not, if he knows how sure-footed he is, and if he is wearing the proper gear, and if he lands properly, he will definitely make it. But if he cannot jump that far, and if he takes that jump, definitely there'll be a problem. So we'll start my case for the day. Somewhat, I think this picture resembles with this case exactly. So taking this challenge, we do not know what is there behind, what is the condition of these iris, pupil, and the capsule, the cataract. So it's a blind game. So until and unless we take that challenge, we won't be able to deliver the result. So taking that challenge and knowing your ability and knowing the complication what you face is very important. So I'll start my talk now. So just to brush up a few points. So just 1 minute. So phacolytic glaucoma is an inflammatory glaucoma where obstruction of the trabecular meshwork is there. Just 1 minute, sir, please. Right. So I'll just start again. Speculitic glaucoma is an inflammatory glaucoma where obstruction of the trabecular meshwork by the lens proteins or the protein-laden macrophages are there, a process that has been shown to be reversible by lens extraction alone. As the lens ages, its protein composition becomes altered with an increased concentration of high molecular weight lens proteins. In mature and hypermature cataract, these proteins are released through microscopic openings in the lens capsule. The proteins precipitate a secondary glaucoma, obstructing the trabecular meshwork. So duration of symptoms should be elicited. A delayed presentation of more than 5 days since onset can result in a glaucomatous disc damage and poorer prognosis. Ocular history may reveal that the patient decided against removal of an advanced cataract, which led to this condition. Visual acuity and visual potential should be assessed and should be prognosticated very properly to the patient. So patient generally presents with acute onset of pain, decreased vision, tearing, photophobia. Examination reveals injection, corneal edema, elevated IOP, anterior chamber reaction. There might be a pseudohypopyon, particles on the lens capsule and anterior capsule wrinkling, etc. A complete ophthalmological examination should be done. The eye will be inflamed and the cornea may be edematous due to high IOP. The anterior chamber will demonstrate massive amounts of inflammation and a pseudohypopyon. Gonioscopy is essential in these cases whenever possible to rule out angle closure due to pecomorphic glaucoma or neovascularization of the angle. And whenever possible, posterior pole examination should be done. And if not possible, then do a B scan. So medical management is used temporarily to control the glaucoma and the inflammation. And the initial treatment consists of hyperosmotic agents, aqueous suppressants, anti-inflammatory drugs, and cycloplegics. The definitive treatment involves removal of the inciting agent, that is the lens, and the residual lens matter. So control of inflammation and glaucoma with corticosteroids and ocular antihypertensive medications is important in order to prevent long-term morbidity. There is often good outcome with prompt and aggressive management in these type of cases. And if the lens is not promptly removed, complications such as glaucoma, hypotony, macular edema, macular scarring can lead to visually significant morbidity. Coming to the first case, which I did during my fellowship days, it was a 66-year-old male who came with pain, watering, redness in the left eye since 4 days. And the vision was PLPR inaccurate. That's the presenting picture. Conjunctiva was congested, no view. There was no view of the AC. It was all white. Cornea had SPKs, microcystic edema. IOP was distally high, and NCT it was 45. So oral and topical AGMs were used. We gave IV mannitol, topical steroids, oral and NSAIDs, and routine investigations along with B scan posted for manual small incision cataract surgery under GVP after controlling the IOP. So that was the post-op day 1 picture. The vision was 6/60. At presentation, the vision was PLPR inaccurate. Now the vision on post-op day 1 came 6/60. Cornea was slightly edematous and few DM folds were there. IOP was 16. We started on intense topical steroids, cycloplegics, and topical antibiotics. Oral AGMs we continued for 3 days, reviewed again after 5 days. So that was the post-op 1 week picture. Vision came to 6/24. IOP was 16. AC reaction decreased, but still there were few lens proteins in the anterior vitreous, which takes time to get resolved. So a long tapering topical steroids were given, and along with that, cycloplegics continued for some time. This was another second case, a 71-year-old female who presented with pain, redness in the right eye since 2 weeks. PLPR inaccurate, similar kind of a presentation. And later on, post of 1 week, this was the picture. And the vision was 3/60. IOP was fine. Few DM folds and spherical degenerations were evident on the cornea. AC cells were present, but slowly, it went fine. So this is the present case, which came to me here in Agra during the unlockdown. The patient could not get operated because of the lockdown. She was a 70 years old female who presented with decreased vision, severe pain, headache, vomiting. PLPR was accurate. IOP was 40 mm at Hg. Cornea had microcystic edema. So we posted the case for surgery, but before pre-op workup, there were certain challenges further associated. First, the cornea had microcystic edema, so we had to bring down the IOP to get the Myers correctly. And then this patient had an axial length of 29. It was a high pathological myope and an extremely deep set eye. So we had a phacolytic glaucoma with edematous cornea, an axial length of 29 mm, and a deep set eye. So we made sure we took the IOL master of the other eye and correlated the axial lens, and then brought down the IOP and gave her topical steroids and cycloplegics and posted the patient for surgery. Pre-op, we gave IV mannitol as well, half an hour prior to the surgery. This was the on-table presentation. This is a short video clip where I'll be playing it. So in these type of cases, I don't care about the incision size, and I prefer to go with small incision cataract surgery. I think that is the safest approach to these type of cases. I give a generous incision, make the tunnel. So I make all the ports first. I make the tunnel first, I make the side port first, and then start with clearing the lens proteins and making the rhexis, so that if I get stuck anywhere, I have all the excess ready. So I made the side port, washed the fluid. So it was well dilated. Stained the capsule nicely, waited for some time to get it stained properly. Washed the dye, filled it with visco, made the entry. Before I start with the rhexis, I made the entry also. Initiated with the rhexis, use the rhexis forceps to complete the rhexis. I got stuck at one point at 12 o'clock. Continued further, completed the rhexis. Here again, I got stuck once again. So what I was expecting a small nucleus, but it came to be a big nucleus, more than my expectation. And the left edge of the rhexis was not letting the nucleus to get delivered with visco. So I tried twice or thrice, then I again put visco and gently I got under the lens and brought it over the rhexis. Took out the lens, checked for the bag, integrity of the zonules, bag looks fine. I made the ACM incision, anterior chamber maintainer, inserted the anterior chamber maintainer, washed the residual lens proteins from the bag and cleared a bit of visco. Again, filled the bag with visco, implanted the lens in under visco only. I used a PMMA lens. I thought it's a better to use either a PMMA or a 3-piece lens in these kind of situations. I don't prefer a foldable lens in these cases. And after nudging the leading haptic, I tucked the lagging haptic into the bag. Cleared the residual visco. Finally hydrated the ports, intracameral antibiotic, and cauterized the conjunctiva. So that was the post-op day 1 picture of the patient. The vision was 6/60 and IOP was 16. And post-op 3 weeks picture, vision was 6/12 and IOP again was 16. So finally, once again, I'll end that these are those challenges worth taking, and the rewards what you get is really gratifying and satisfying. Thank you.
Thank you, Dr. Mayank. That was a really great presentation, and the outcomes pre-op versus post-op is really astonishing. Few quick comments from Dr. Harsh, Dr. Lalit, and anybody else who would like to chip in about the use of steroids when the IOP is raised in a phacolytic glaucoma. A lot of young surgeons like me, they refrain from use of steroids in all situations where IOP is raised. So what would you like to say about the use of steroids that Dr. Mayank said?
Harsh, comment actually. Harsh.
Yeah, okay, there are 2-3 things. Mayank, excellent presentation, but I think you have to challenge yourself a little bit more, because please don't mind if me or Lalit tell you certain things, which, because it is very easy for me to say, oh, wonderful, you are fantastic, you are this and that, but that way you don't learn anything. Okay. And me and Lalit have more age in ophthalmology than you are actually old. So don't mind at all. Huh? So, Mayank, such a wonderful presentation. I can see from your flow also that you are such a good presenter. So don't read your slides. Don't make your
You are
slides.
not audible, Harsh.
It's audible.
I can.
I'm not audible to you because you don't want to listen to me. Okay, so keep the slides short. There are multiple things in especially in the first case, you were just reading out point by point. That is not to be done. Okay, so make one point over there, and the rest you know, because your flow is so good, your English is so good, you can just take it over. Because as you grow older, that is the way you present. You don't start reading from the slides. Okay,
Right.
that is number one. Second thing is that the SICS that you make, you always should in these situations make it from the temporal side. Because if tomorrow you have to do a trap, तो भाई कहाँ से करेंगे trap? Trap कहाँ से करोगे बताओ? कोई जगह नहीं बचेगी ना. टेम्पोरल हम जा नहीं सकते, इंफीरियर जा नहीं सकते, फिर ट्यूब ही बचेगा करने को. क्योंकि मैं कई बार ये भुगत चुका हूँ, मैंने सोचा ही नहीं, मैं सोचा हम तो दिमाग चलता ही नहीं ना कि भाई फेंको ही होगा, और खोला तो देखा इतना बड़ा ऐसा किसी इसका इंसिडेंट पड़ा है. देन उसमें फिर ट्रैप करना बहुत ही तमाशे वाली चीज है. So please always.
glaucoma specialist है, you should remember that.
हाँ यही होता है ना भैया. तो तेरा रेटिना में क्या मिस होता है बताऊंगा बाद में.
Yeah, baculitic glaucoma में there can be no. We should say that there is a risk of post-operative glaucoma as well in these cases.
हाँ हाँ नहीं मतलब yeah, it's definitely
so trap may be required. So
yeah. Definitely. So it is always, and the surgery is so good. So I think he can sit anywhere and do it from anywhere. So that will be really wonderful. And third thing, which I think the cataract surgeon should say, but whenever I deal with this kind of a this thing, it is always better to initially make a 3 millimeter, 2 millimeter rhexis, suck out the fluid from inside, and then enlarge the rhexis. Otherwise, it is bound to run out somewhere. And what Prakhyat told was that steroids, yes, you have to use steroids because the inflammation is the major thing over here. So I think these are the important points.
Even in ACG, you see ACG, faculty glaucoma, since inflammation is there, so we used to give betnisol and drop steroids topically to control, because the post-op quiet eye is more.
I just wanted that point to be emphasized more, because a lot of people refrain from doing that, and then the inflammation continues and doesn't settle. So there are a few situations where the IOP is raised and still you give steroids.
There's another question from the in the chat box. How did the patient have high IOP in case 3? Usage of superior SICS that I think Harsh has covered will make the trap difficult. So I don't know. The first part is, how did the patient have high IOP?
How long did the patient have high IOP? I think Dr. Mayank.
I'll answer this patient, sir. I started this patient with steroids and along with that IOP lowering agents also, but I could not see a lot of lowering down of the IOP. So I thought, now I have to operate this case as soon as possible because the IOP was not coming down. So I gave on the day of surgery 2 stat Diamox, mannitol, lowered it, and night before surgery also I asked the patient to take 2 Diamox, and then I planned it for surgery because the IOP was not coming down.
So, any patient, when you do combined surgery in such patients, or it's always a cataract only?
So, if the pressure is not come, there's a beautiful paper by Berganza from Vellore, and he has done a huge survey. And basically, if the pressures, if the thing is more than 1 week old, or despite mannitol, glycerol, everything that you can possibly give, the pressures are not coming down, it may be preferable to do a combined.
In the first go?
Yeah, in the first go. Yeah.
So, I think that's a good point to be taken, because you see, most of the times we see the cause of the glaucoma as lens, take out the culprit, lens is out, and it should, like in phacomorphic, phacolytic, causes the lens, you take out the lens. But I think if it is not coming down with all these agents, then I think it makes sense, and even counseling may be also important in such patients.
And Lalit, I think Babu had also said that point, and let us reiterate that point. That only comes with age. That you might not, instead of saying that you have a 40% chance, you have a 20% chance, you have a 60% chance, we never say that. You just tell them that we just don't know. We will do our best, and it is likely that you may gain a whole lot of vision, or you may not gain any vision at all. So
Yeah.
leave it like that. Don't ever give percentages, because then it becomes very tricky.
I remember that Romy also was presenting that 41%
हाँ, ये
chance.
रोमी के लिए ही बोल रहा हूँ मैं. ये बाबू ने वहीं पे बोला था. और मयंक ने ये बहुत अच्छा पॉइंट उठाया था कि डिस्पाइट पीआर बीइंग इनएक्यूरेट, so many times we can get 6/6 vision from an angle.
Yeah.
So it is worth operating even PR inaccurate patients.
ये केस इसलिए लिया था because यहाँ पे this case went to a local clinic आगरा में ही, where he was told कि ये आंख तो जा चुकी है, आप दूसरी का कैटरेक्ट करा लो. So that's why I took this case, because still people they think कि this eye is gone.
I think
Easily challenge the limits. इसलिए limits.
Yes.
that's the basic take-home message that Dr. Mayank has given, that we have to tackle such situations proactively, and at our clinic, based on our capabilities, we can do that. I think that's what he wants to send across the message.
And Dhruv, before you go to the third presentation, first slide, everybody.
Before we
slide was the best.
उसमें वो आदमी चप्पल पहने हुए ना, मेरे ख्याल से चप्पल पहन के कूद रहा है.
Gear proper नहीं है.
Mayank, in one of the cases, you used Vectis.
In this case only I used
appears to be adequate, though the nucleus appeared little large. The rexis appeared adequate.
So the left margin of the rexis was interfering. So I tried once, twice, it was not coming. Though I was very apprehensive in using the Vectis, I was very scared. But I inflated the bag properly with Visco. Carefully, gently just brought it down the lens and under the lens and brought it over the rexis and took it out.
So Mayank, we had forgotten, we forgot this instrument actually. You see now.
Not only that, it is a little bit dangerous also, especially in phacolytic glaucoma.
But to be honest, while speaking, even I forgot the name of the instrument. So I didn't speak Vectis.
Okay.
Can I make a very comment?
Yeah, Mukesh.
Yeah. Very nicely managed case, Mayank. It was really difficult, and you did very well. Only one small suggestion, that always try to apply one suture. Dr. Harsh will agree with me. We learn these things with age. All cases wherever high post-operative pressure may be anticipated, wound has to be watertight. In these SICS 5-6 millimeter tunnels, sometimes you may have post-operative shallow or leaky wound, and then you will have peripheral anterior synechiae and whole lot of other things. Patient may not come to you for a regular follow-up. So I think better to put one suture. I think for all SICS doing people, this message should be there.
Right, sir.
Great. Good point.
So great discussion. I think now we can move on to our next speaker, Dr. Lalit Mohan Rastogi. He's a very experienced surgeon. He's from CFS Moradabad. He's been in practice since 1989, when he completed his post-graduation from King George Medical University, Lucknow. And apart from cataract, he has a special interest towards basic oculoplasty procedures. He has a prolific career, and he has done many community phaco surgery camps in Uttarakhand for the past 18 years continuously. He's going to discuss a case of canalicular abscess today. Over to you, Dr. Lalit, sir. You can start sharing your screen and unmute yourself.
Sir, Dr. Lalit is not there. I think we lost him.
Lalit Verma is there, but Lalit Mohan has to be here.
I think there's been some lapse in his connection. We've lost him. So should we move on to the next journal club in the interim?
Correct.
We'll have Dr. Geeta Chauhan, who has been working at CFS Meerut for the past 9 years. She did her MBBS from MAMC and her post-graduation from Safdarjung Hospital. She is going to discuss a very important topic today, the prevention of CME post-cataract surgery through a journal club. Let's have Dr. Geeta's presentation now. Dr. Geeta, can you start sharing your screen? Also, you can unmute yourself, ma'am, so we can check.
Is it visible?
You're audible, but I can't see your screen.
Okay.
I think Dr. Lalit Mohan is also back.
Is your PPT opened, Geeta?
Yeah, I had opened my PPT, I think.
Need to-
Actually,
Ma'am,
I was
you
not-
need to screen share first. Just click on the green button on the bottom on the screen, share screen.
No,
On
no.
the Zoom
Priyank need to come out of screen share.
No, he's
Then
out of.
Geeta-
He's out, sir.
Geeta-
He's out. He's out, sir.
He's out. Okay. Yeah. Now.
Ma'am, can you just click on the screen share button?
Screen share. It's bottom. It's bottom. It is
The bottom green button on the window.
green
ma'am.
button.
On the Zoom window.
Yeah, I'll just take a minute.
Dr. Geeta, if it's taking time, can we have Dr. Lalit Mohan? He's back.
My internet is also not working properly.
Dr. Lalit, I can play your presentation if you can speak on the audio.
Am I audible?
Yes, ma'am.
You are audible.
Ma'am, you are audible.
Screen share, is it visible?
No, ma'am. You first click on the green button, ma'am, on the screen. Green button on the screen, which says share screen.
Yeah.
आपका window
Share
आ रहा है.
screen, green button.
I did that actually.
No, you haven't done, ma'am. एक बार
Okay.
आप click करिएगा. It will open up a pop-up on the right-hand side. There is a blue button which says share. Just click on that. Now it is good. Yeah,
Seen?
ma'am. Yeah, ma'am.
Can you see now?
Just a minute, ma'am. Just a minute, ma'am. It is still opening. Yeah,
Yes.
perfectly fine, ma'am.
Yes, we can see.
All the best, ma'am.
Okay, so good evening, everybody. Thank you, Prakhyat, for introducing me. So I'm Dr. Geeta Chauhan, and I'll be talking to you under General Club about prevention of macular edema after cataract surgery, which also goes by the name of pre-med study. So this was pre-med study was an ESCRS funded study. It was a first very large multi-centric study, which was double masked, and also it was a randomized control trial, which happened.
Can't see your slides moving, Dr. Geeta.
See?
We can't see your slides moving.
Okay, I'll just.
You have to share yours. Yeah, now we can see.
Can you see them moving now?
Yeah, that's fine. Continue.
Okay, fine. So this is my first slide, and we are talking about the pre-med study, which was conducted from 2013 to 2016. The recruitments ended in 2016, and it was funded by ESCRS. It was the first very large multi-centric randomized control trial, and it was a double unmasked study. And the main aim of the study was to find out various methods to prevent cystoid macular edema after the cataract study in mainly two groups, the diabetics and non-diabetics. So the study was conducted mainly to give evidence-based recommendations so that we can formulate various clinical guidelines for all the ophthalmologists. The cataract surgery being the most common surgery that ophthalmologists do. And the cystoid macular edema is one of the major causes of suboptimal visual outcome, which we encounter in uneventful cataract surgeries, both in diabetics, more in diabetics, and to a lesser extent in non-diabetics. So this was required because all the previous studies were very small, and they were not powered enough to give clinically significant data to decide the guidelines. So this study was warranted. So this study involved more than 1,000 patients, which were divided as diabetics and undiabetic groups. So this is to say that the cystoid macular the development of cysts, edema, and macular thickness in the inner nuclear and outer plexiform layer. And the maximum incidence happens at 4 to 6 weeks, but it can happen even up to 12 weeks. So the main pathology, pathogenesis is like inflammation, postoperative inflammation, blood-retinal barrier, release of inflammatory mediators, and transudation of fluid, leading to the edema and cyst formation. So this is the basic design where I already told more than 1,000 patients taken, double masked, randomized, started in 2013, ended in 2016, and the results were then analyzed and the study was printed in Journal of Cataract and Refractive Surgery in 2018. This is all about the centers involved. And this is the aim, as we have already said, to give the clinical guidelines for prevention of CME. So let us talk about the design of the study. A lot of patients were screened, out of which 1127 patients fitted the bill after exclusion criteria. And various exclusion criteria were used, like removing the intraocular inflammation, traumatic cataract, anti-glaucoma therapy, therapies involving NSAID and corticosteroids, any intravitreal anti-inflammatory injections, pseudoexfoliation, fuchs endothelial dystrophy, and IOP of more than 25 was also excluded. So this is the and this is the diabetic group. So diabetics were 213, non-diabetics were 914. In the non-diabetic group, there were three groups into which the patients were randomized. First one was given bromfenac 0.09% by daily, starting 2 days prior to the surgery and continuing up to 2 weeks after the surgery. And this is the dexamethasone alone group, in which 0.1% dexamethasone was given 4 times a day, again starting 2 days prior to the surgery and continuing up to like 4 weeks. And in this, tapering was done after 1 week on the basis of 1 drop decrease per week in the subsequent weeks. And the third group was the one in which both the therapies were given in the same manner. So we are talking about the diabetic part first, non-diabetic part first. These are the 3 groups therapies I have already said. This is bromfenac, dexa, and combination. These are the 3 groups. So the study outcomes were monitored by the investigators, basically the people who investigated the retina, the macula, based on ETDRS 9 sector pattern, in which the central 1 millimeter circle, then 1 to 3 millimeter parafoveal concentric circle, and 3 to 6 millimeter perifoveal circles were studied. Thicknesses were made out, and in all the groups, these thicknesses were compared at 6 weeks interval, 12 weeks interval, and also they were compared with the baseline preoperative level. This was mainly done with the help of SDOCT, main OCT, and all the data was collected and then later on analyzed. These were the criteria which define the CME and CSME for this study, in which the cystoid macular edema subfield macular thickness of more than or equal to 10% on comparison with the baseline, that is the preoperative CSMT. CSMT is the central 1 millimeter concentric 1 millimeter circle, which is the most important, and also the presence of cystic changes in that. And the clinically significant macular edema was taken to be as an evidence of CME on SDOCT, along with the less than 0.2 logMAR CDVA improvement as compared to the baseline CDVA. So here CDVA is the corrected distance visual acuity. So these were the 2 definitions which were used to define CME and CSME. If we look at the main outcome, the main outcome was that the central subfield macular thickness was maximum in the dexamethasone group. This is the dexamethasone group in the center, and it is more than the combination, as well as it is more than the bromphenic alone group. The lowest being the combination group, that is the combination of bromphenic and dexamethasone. However, in spite of the difference in the CSMT, which was significantly higher in the DEXA group, the combination therapy group, the CDVA was comparable in 6 weeks and 12 weeks interval time in all the three groups, bromphenic, DEXA, and combination. The three mean CDVAs were comparable, and there was no significant difference. If we look at the bar graph at 6 and 12 weeks in the incidence of CME, then there was a significant difference between the 6-week incidence of CME in the combination group as compared to DEXA, and also 12 weeks CME incidence as compared to in the combination group as compared to DEXA. So here we can inference that the CME was least in the combination group, both at 6 weeks and 12 weeks. At 12 weeks, the risk of CSME was 1.5 in combination, 5.10 in DEXA. Although this was not clinically significant, but this is a huge difference, thereby giving an evidence that this combination therapy is a good therapy to reduce the CME. So the paper adds that although the topical bromphenic 0.09% and dexamethasone, the combination was not clinically more effective than bromphenic alone in reducing the macular thickness, macular volume. But if we look at the overall incidence of CME, that was definitely a combination treatment. Also, the odds for developing clinically significant macular edema at 12 weeks was 3.7 in DEXA and 2.6 in bromphenic alone groups, which was quite significant when compared to the combination therapy. Coming to the diabetics, the study mainly aimed to decide whether any perioperative treatments could reduce CME in diabetic groups. So diabetic groups were again divided into 4 groups. One was control, which was only given NSAID and DEXA topical, then intravitreal bevacizumab, and subconjunctival triamcinolone acetonide 40 mg, which was given bevacizumab and TA both. TA is the triamcinolone. Here what we found out that intravitreal bevacizumab had whatsoever no effect on the central subfield macular thickness in all the groups. So here, if you can see this chart, this is the group which is the bevacizumab group. This is the control group, and this is the triamcinolone acetonide. This is the combination group. So both had 6 weeks and 12 weeks. If you can see that this is the bevacizumab group, it is having the maximum CSMT values as compared to all other groups. Again, but in diabetics also, the corrected distance visual acuity is comparable, 6 weeks and 12 weeks across all the groups. The surprising and very nice thing that this study told us that the triamcinolone group in this at 6 weeks and 12 weeks, there was zero incidence of CME. So none of the patient in the group with TA or with combination, they developed any CME, whereas the CME incidence was quite high in which TA was not given. That is the bevacizumab group as well as the control group. In both these, the incidence of CME was very, very high. Again, these are the 2 groups with bevacizumab, without, and the incidence of CME at 6 and 12 weeks is very, very high. So what this the study also had to take into consideration the IOP elevation that happens along with the injections, which is found to be 20% in previous studies, but in this current study, the incidence of IOP elevation more than 25 was 7.1%, and all were well medically controlled. Only one patient needed a subconjunctival resection of the lipo injection. This is the IOP elevation. So the study that 40 mg triamcinolone is very, very effective in controlling CME within 12 weeks after cataract surgery. However, there is a risk of increased IOP. Intravitreal bevacizumab has no significant effect on post-operative CDVA on macular or macular thickness in the diabetic population after cataract surgery, provided this population had no pre-existing diabetic macular edema or any proliferative diabetic retinopathy or severe non-proliferative diabetic retinopathy.
Thank you for that discussion. Dr. Lalit, your comment on finally what to do in a diabetic patient undergoing cataract surgery to prevent CME.
You see, this powerful study definitely tells that the only thing which works is age-old 40 rupees injection, that is IVTA, and not hyped anti-VEGFs. In fact, we have been telling for a long time that anti-VEGFs have no role because CME is not a VEGF-related disease at all. There are so many studies available on aqueous taps and vitreous taps where VEGF levels are normal. So it does not make sense to give any of the anti-VEGFs in CME. So what we have been following for a long time as a treatment, this was prophylaxis, as a treatment is IVTA if the vision is compromised to less than 6/12. We don't depend on anti-VEGF at all. And this study has brought out very effectively. The only question, which is slightly, because this is study concluded in 2016. So there have been more articles on this after that, where you see bromfenac OD dose has been used rather than BD use. And you see a couple of weeks back only, I heard one very powerful speaker from US. He said, one drug, one drop. One drug, one drop. And 10 बार उसने बोला कम से कम, one drug, one drop use karo, and this CME does not occur. So meaning therefore, this again was a bromfenac study, and he said that he does only bromfenac and nothing else. एक ही drop देता है. And this study has a lot of repercussions from our approach also. That age-old IVTA is good. We should depend on that not only from treatment point of view, but also like she has shown prophylaxis. Although 7.51% figure is still on the higher side from the point of view of IOP elevation, it can't be taken lightly. But you see, clinically, there's no way to find out steroid responder because it takes days and weeks to find out who's a responder.
ललित pre-op में एक बार clarify कर दो, pre-op में should we start bromfenac क्यों diabetic 10% तो almost diabetic ही होते हैं हमारे cataracts.
Yeah. That's what I was coming to. It does make sense. Yeah. I'm coming to that. That preoperatively in diabetics, I would say otherwise also 2 or 3 days prior to your surgery, no harm in starting one drop, one drug bromfenac.
So I think this should be told to our because nowhere in our pre-operative charts is this thing being taken up.
NSAIDs have gone through a lot of turbulations. You remember once you had done some work on ibuprofen drops also, long time back. I remember that work also. So ibuprofen, ketorolac, then bromfenac, napafenac, then amphenac, prodrugs. So many are coming up. So, but a lot of these studies now show conclusively in predisposed eye, like Geeta has told very clearly, diabetics are one group which are predisposed. So at least in those groups, it does make sense to start bromfenac early. That means 1 or 2 or 3 days prior and continue for at least 2 or 3 weeks post. Yes, Geeta, you want to say something?
Sir, nothing. You have very lucidly explained. Yes, this is what I was also thinking of. The study that pre-operatively I have never seen anybody starting NSAID.
Yeah. I think Harsh has a point. All of us, you see, beginning from Center for Sight at headquarters and everywhere, in fact, all the all practitioners, why only CFS? Everybody should try to adopt this regimen. Times again, it has been stressed so many times that in susceptible eyes, like uveitis, like diabetics, like previous eye having developed CME, so such patients should preferably be started, or must be started, bromfenac 1 or 2 days prior and continued along with steroids. Steroid post-op you can taper fast, in fact, over 2-3 weeks, and bromfenac continue for a couple of weeks.
Another very perplexing thing, sir.
Say it again.
That, we are having a lot of diabetic cataracts these days, and those whose retinas are normal on OCTs and everything. So how to decide which patient?
It does not matter. You see, Geeta, it does not matter that you see diabetic. In any case, diabetic cataracts, diabetic patient itself is a pro-inflammatory state. Cataract is another pro-inflammatory state. We are adding insult again to the fire. You see, diabetic control and presence or absence of CSME does not necessarily mean that he will not. Just the diabetic state itself predisposes for more macular edema. You see, there could be 2-3 instances. One is no macular edema before, no diabetic macular edema. Then we can have, mild NPDR with some kind of CSME already there. In those patients, it's always prudent to start, because Irvine gas syndrome can add on to the diabetic edema also. And this does help in those patients. And I would say even in patients who do not have, you see, these patients who do not have CSME or maculopathy at all, like you're saying, they also, tend to develop less.
So one question to the panel is ki if you develop a CME, then when do you recommend to give intravitreal DA or posterior subtenon? What should be the time period? That is very important because you should not jump on to the treatment.
You see, this study was focused primarily on preventive aspects. So what AG is asking about the treatment point of view. Treatment point of view, I think it is a combination of degree of edema as well as visual acuity. Suppose degree of edema, you see OCT changes do not parallel the visual acuity. So if the vision is less than 6/12 or so, I will not depend only on drops. I will definitely give subtenon IVTA. This does help to hasten the, as for treatment, what you're asking, AG. So if the vision is say 6/9 or, then this bromphenic drops can be started and continued, but follow up this patient after 2-3 weeks, 4 weeks, and then evaluate on OCT. Has the edema gone down? Has the vision improved? If not, do not hesitate to give IVT injection subtenon.
No, sir.
I'm not talking of intravitreal, believe me.
No, what I wanted to ask was, will you wait because we know many of the CMEs tend to resolve in a normal course.
Absolutely.
So, will you like to continue for drops for what period of time, and when will you subject your patient to posterior subtenon steroid? After maybe 2 months, 6 weeks, what will be the time period?
So I know that CME has a spontaneous resolution in more than 90% of the patients. It resolves spontaneously. So vertical follow-up will tell you. You see, you have seen the patient. In any case, first 2 weeks does not make sense to give IVT at all, because the peak incidence also, because first 2 weeks you follow these patients, and even if OCT shows CME, it does not make sense. So I would say after 4 weeks, you should be on the guard, and especially the vertical follow-up has shown vision going down than what it was at 3 weeks, then you should definitely be on the guard that you may, after 4 weeks, answer to your question, after 4 weeks, not less.
Okay, so I think with that, we should move on now to Dr. Lalit.
Geeta, do you have any further comment? Because you must have studied quite a bit about CME.
It's the dose and it's only the diabetic part of the study.
Dose, I think I tend to give lesser than this. We do not give so much dose of IVT also.
So it's less.
Lesser than this.
We are giving 0.5 ml of subconjunctival, posterior subtenon injection. We are giving it at CFS mirror. And we are not seeing many cases of rise in IOP post-operatively.
Yeah, that's more hyped. In fact, if you do long studies, then maybe, because our numbers also not so much.
Yes.
Because
I don't know how they have quoted. They have quoted previous studies to be showing up to 20% rise of IOP in subconjunctival. They have quoted. I don't know. Yeah.
Okay, so I think we can now move to Dr. Lalit Mohan Rastogi's presentation on canalicular abscess case discussion. So you can start sharing your screen and unmute yourself first, and then you can start sharing your screen. Yes, we can see your screen, sir. Now you can. इसको minimize करके सर presentation खोलना है.
Open the PPT. इसको minus करो सर.
Am I visible? Audible?
Audible, yes. Yeah. You visible also. दोनों ठीक है.
Am I?
Yeah. Both are okay.
Hello. Yeah.
Carry on, Lalit. Carry on.
Presenting a case of canalicular abscess. Yes, sir.
We can't see your screen, sir. Would you like it?
गायब हो गया.
Treated at places, but
Hello.
दिख नहीं रहा.
these are few pictures.
डॉक्टर ललित, आपका स्लाइड शो दिख रहा है सर.
स्लाइड नहीं दिख रहा.
नहीं, आप what we can do is I'll play your slideshow. You can just switch off your video and you can speak as I share.
Okay.
आप दिखाओ.
जी.
Then where is the video?
Can you see now?
Yeah, we can see. We can all see.
Dr. Lalit Mohan, you can start.
आप बोलो sir.
Yes, sir. Of the left upper lid medial side with mild tenderness and next slide. Next. The vision was 6:9 in both the eyes. The right eye was almost normal. There was minimal conjunctival congestion with epiphora, and there was no punctum plug detected. So a diagnosis of canaliculitis oblique canalicular abscess was made. Next slide, please. The investigations done is most important is sex syringing. That is done from the lower punctum and it was patent. The blood sugar was normal and the punctum plug was not there. Next slide, please. So I initially thought I should start a medical treatment. I started with hot fomentation with massage 3 times a day with antibiotic ointment and oral antibiotic and anti-inflammatory drugs. Sign and symptom decreased up to a limit. For the next 5 days, I thought I should also give for next 5 days. After 10 days, the patient didn't turn up for a month. Next slide, please. Then again, she came with the same complaint and same swelling over the left upper lid medial side. So I thought I should do a surgical intervention. I should dilate the puncta and do the canaliculotomy and curettage of the abscess. So after dilating the puncta, I pressed the lesion on from both the sides with cotton tip applicators so that some pus came out, but totally it was not drained. Now I increased the incision with the help of Bart Parker 11 number blade, the sharp edge upside anteriorly on more on the conjunctival side. Now I was able to introduce curate and I curated whole of the abscess. And post-operation, after curettage, we give betadine wash in the cavity and the sample was sent given to the patient for the purpose of culture and sensitivity. But that was not done by the patient. On post-operatively, I gave oral anti-inflammatory and oral antibiotic drugs with topical antibiotics and slight fomentation with massage. I followed the patient for 3 weeks. Then she didn't turn up, but up to 3 weeks there was no complaint and the swelling subsided. I thought it is an uncommon chronic condition, usually misdiagnosed with chalazion or STI. I don't have the original photographs because I never thought I have to present a paper in coffee with CFS. And secondly, we don't have a camera attached to our microscope. Thank you very much.
So Mukesh or Santosh Manawar, we need your help. Mukesh, can you comment on this? Santosh?
Nicely presented case. Generally, this canaliculitis is caused in India by actinomyces, streptothrix, etc. In West, herpetic infections are more common. And if we choose antibiotic for this, we have to really give one antibiotic which is effective against these organisms, typically azithromycin or sulfonamide like cotrimazole is the drug of choice if patient is not allergic, and these drugs have to be given for a longer period of time, around a month or so. Drainage is important. Punctum dilatation, as Dr. Lalit has mentioned, along with punctal snipping, if not a generous cut, I think a little bit of punctal snipping and then drainage by 2 swab sticks, one underneath the lid, other over the lid. Patient also should be explained about this massage, and patient has to continue with this massage along with proper antibiotic. If culture is not done, then typically azithromycin, or one can give sulfonamide cotrimazole into if patient is not allergic to sulfa drugs. But drainage is very important, and patient has to continuously do it for around at least a month or so. But as a whole, nice case.
You mean to say post-op patient has to keep
Yes, because these infections are chronic infections, and lining of canaliculus is persistently infected with these organisms. So it takes some time for infection to be eradicated. So in post-operative period also, we'll have to explain it to patient that patient will have to use 2 buds, one underneath the lid, other over the lid. It's not difficult once you explain patient or attendant in your OPD, like they are able to do it. So in post-operatively also patient has to do it. But generally a small punctal snipping is sufficient.
So only dilatation will not do. It has to be punctal slit combined, like he should.
If the swelling is significant, if swelling is not too much, it means the canaliculitis and abscess part is not very large, then repeated punctal dilatation also may help along with the pressure expression. But expression of pus is of paramount importance.
Yes, Santosh.
Yes, sir. Mukesh has covered almost everything, but yeah, dilatation generally helps. And if you milk out those sulfur granules kind of concretions, actinomycotic, which is the most common etiology, then couple of sessions and patient self-expression is all that is required. And antibiotic, earlier we used to use penicillin drops, but no longer that being available, we can use ciprofloxacin as an alternative, systemic as well as topical, which is to which actinomycosis is sensitive.
How common is this condition? Because either, like he said, Lalit Mohan said, that we misdiagnose, or common, comprehensive surgeon may misdiagnose to be something else. But how common is it? Because I rarely see. Maybe
it's quite common. So once a month we get to see one. It's not that common as compared to chronic dacrocystitis, etc. But maybe 10 to 12 cases a year.
It is around 3% of all the lacrimal.
Nice case. Nice learning for comprehensive ophthalmology, where we don't see these things at all. And we refer, because I think it has to be a specialty case. It can't be tackled by a comprehensive. You see, I agree, you take 2 swabs and massage, but I think once the surgical part comes, it has to be done by Mukesh or Santosh.
I think the take-home message from this presentation is that as somebody who is not specializing in that specialty, we should be aware that there can be cases who will not get treated for their inflammation and relieved of their symptoms with our usual treatment, and then we should suspect such a thing and refer them to the concerned specialists.
So there are some questions here, Dr. Lalit Mohan. What is the percentage of problems post-punctal plug?
Post-punctal, sir?
Punctal plug, post-punctal plugs.
Yes, sir.
What problems normally patients face? You have put
if there is punctal plug, there is a obstruction in the drainage area. So the pus and other secretion usually collect inside the cannucula. That get thickened and work like a stone. Those are known as canaliculolith.
Okay, that's
so you have to remove the punctum before treating this.
So I think what
But
Rupal
for
Shah,
the lower punctum, it is more difficult.
what Rupal Shah I think wanted to know was generally what is the percentage of problems post-punctal plug whatsoever you put.
Migration is an important problem. So it migrates posteriorly. It may migrate into the canalicular system or migrate into common canaliculus and sometimes even into the NLD, causing nasolacrimal duct obstruction. So migration, when you don't see a punctal plug in position, there are only two possibilities. One is that it has got extruded out spontaneously or it has posteriorly migrated.
And can the patient do it self-expression without putting any lignocaine or paracaine drops?
Punctal plug?
No. Like Mukesh was saying that patient has to be taught how to do self-expression and massage at home. And can the patient do it himself, this without any paracaine drops? I think
Yes.
Yes, sir. Actually, patients are able to do it. And I think I have seen now maybe around 20-30 cases. People are they are able to do it pretty well. And these kind of chronic infections, I think it is not that painful also. So they are able to do it.
Okay. Thanks a lot.
So I think we can now move to the next clinical talk by Dr. Roop. Dr. Roop did his medical education from the All India Institute of Medical Sciences and has been practicing ophthalmology in Meerut for the past 31 years. Apart from his expertise in cataract and IOL, he has a lot of interest in glaucoma, and his clinics actually are comprising of the pan-ophthalmological spectrum of patients. So he sees a lot of all things, and I think with that, I will let him speak on his innovative approach to glaucoma surgery.
Before Roop starts, let me add something because I have known Roop for more time than a lot of people on the screen, because Roop has been with us at our AIMS RP Center for a very long time. A silent worker, but a very, very nice surgeon. In fact, he is our face in Meerut. And a lot of people may be knowing that his wife is a retina surgeon, beard surgeon. And Prakhyat, whom you heard, is illustrious son of Dr. Roop, and already won a lot of glory to his credit. And he has won a lot of international awards also. So let's congratulate the entire Roop family, consisting of Roop, Prakhyat, and wife, Madam also. Yes, Roop, you can carry on.
Thank you, Dr. Lalit. Thanks a lot. पर ग्लॉकोमा सर्जरी की बात है तो शुरू करूंगा डॉक्टर हर्ष का नाम लेके. So 30 years ago, when I started practice, I started getting patients of glaucoma also. And at that time, the standard was the limbus-based flap, and things looked like this. Initially, 1 or 2 trabeculectomies I did with the limbus-based flap, but I couldn't really do it. So I did not like the technique. I started doing phacoemulsification, and soon I devised my own technique, which was based mostly on the steps of a phacoemulsification surgery. I started getting motivating results, and I gathered the courage to publish it. In fact, I tried stitchless trabeculectomy at that time, and I published it in September 2004 in Delhi Journal of Ophthalmology. I was emboldened when in 2009, Moorfield came out with safer surgery system. And 2 of the common things that I was already doing, flap. Another, they advised that the trabeculectomy flap, sterile flap, should not go up to the limbus. So they, to facilitate the posterior flow of the aqueous. What I was already doing, I was not making any side cuts at all. So what Moorfields decided in 2009, I was already doing it, and I was doing it probably in a much better way than ultimately it was decided by the Moorfields. Furthering the evolution of this technique, then I conceptualized an idea of supplementing the natural meshwork with an artificial meshwork. I thought rather than having a channel, open channel, it would be much controlled if the channel consists of a meshwork, so that there would be lesser chances of overfiltration. So this glaucoma wick that I started experimenting with, it is a device for which patent is pending. Right now I am using it made of glycosaminoglycan matrix, and basically I put it in the anterior chamber and it continues up to the subtenon level. So it works like a wick. जैसे दिए में बत्ती होती है, उससे कोई फ्लूइड सक होता है, उसी तरह से इस विक से the aqueous gets sucked to the subtenon space. The principle of functioning would be the Darcy's law. That is the flow which is regulated through a porous material. Just to elaborate the concept, you take two bowls in one, take a solution in one bowl which is at a higher potential, and you put a gauge between the two. You would see that gradually whole of the fluid would be transferred to the lower bowl. And despite this barrier being there, which has a higher potential energy, it passes through that. So basically the capillary action even allows it to overtake this difference in the pressure gradient, and it can still flow out. So the capillary action of the wick overcomes the barrier of higher energy also, and the fluid keeps percolating through the wick. Now this is the surgical technique. I have also devised a specific speculum for doing trabeculectomies. Here I don't require any sutures to retract the eyeball down, neither in the superior rectus nor in the cornea. The principle is that the speculum retracts the upper lid more and it pushes the eyeball down. So this is what this speculum looks like. It has basically unequal positioning of this screw. So one of the arm of the speculum retracts the eyelid more than the other arm. So the requirement of the bridle suture is altogether taken care of. You can see this distance is lesser than the design, helps you doing a glaucoma surgery without any bridle suture. Now we go on to the surgery itself. So as I told you, I have never done limbus based flaps. I do Fornis based flaps only, which is dissected and pockets are dissected posteriorly. Then all the bleeders are cauterized with bipolar cautery. I make a partial the limbus, anterior limbus. Then, as we used to do with our scleral tunnel cataract surgery, I use a crescent knife to dissect the tunnel up to the clear cornea. I'm sorry, because of the probably internet connection, the streaming is not good. So I reach up to the clear cornea. Then I make a side port incision. First I put pilocarpine to constrict the pupil and basically safeguard the lens. Then I put the viscoelastic to safeguard the cornea. When both incision at the junction of gray and white and enter a bent keratome into the AC. So now anterior and posterior cut of the trabeculectomy block are over, which are combined by two side cuts. So this completes the trabeculectomy without any special instrument. The instruments that we use for cataract are good enough. Iridectomy is done. Initially, I used to leave this as it is and just cauterize the conjunctiva. it used to lead to a lot of hypotony. So I decided to give 2 Vicryl 10-0 Vicryl sutures. I prefer Vicryl because most of the time they become loose after 2 to 3 weeks. So basically the effect of suture removal is spontaneous. You don't have to do anything. 10-0 Vicryl gives you adequate strength at the time of surgery and later it sorts of dissolves. Then this is the wick, which is the broader portion is put in the subtenon space and the tapered So basically what you have that the trabeculectomy ostium is filled with a spongy tissue. So there is never a free flow of aqueous. Now the conjunctiva is closed by 3 mattress sutures, 2 on each side and 1 in the center. By the time you finish suturing the conjunctival flap, the bleb already starts forming. It is very evident in the video. At the end of the surgery, once the conjunctival closure has to be meticulous, there should not be any leakage. You can put trypan blue over it to do a Siddle test to confirm that there is no leakage. At the end, from the side port, you can inject the fluid and you can see how this spongy tissue is working. You press it, it bounces back. The aqueous is already coming out. So the basic premise was that any cataract surgeon can do trabeculectomy, but most of the time we are not doing it because we don't have much control. Either we land up with overfiltration or we land up with failed surgeries. So most of the cataract surgeon avoid doing glaucoma surgeries. When you have to do combined, I use the same incision to remove the cataract, insert the lens, and then rest of the steps of trabeculectomy are accomplished. So basically, if I do a combined surgery, it is just 3 more minutes that I have to spend. Suturing takes some time, but the trabeculectomy part doesn't really take any time. So it can easily be done as a combined procedure. I have had only one complication.
Your presentation has frozen, Dr.
It's okay now?
No, you can stop your presentation and start again from this slide.
Okay.
प्रख्यात तो जर्की चल रहा है बट चल तो रहा है.
Sir, I think he has moved on to the next slides, but his
video has to stop.
Has frozen.
Yeah.
So you can continue actually with this.
ठीक है रूप.
Okay. So basically, with this technique, I am able to prevent the hypotony, immediate hypotony, and also I am able to get good results, good surgical success rate as far as control of the IOP is concerned. The advantage of this technique is that it can be customized also to a particular patient's requirement. The 3 customizable issues that are specific to this process is that you can vary the size of the wick. Broader the wick, more is the filtration. Secondly, you can apply the releasable suture because if you compress the wick, there would be less filtration. So as soon as you remove the suture, there would be higher filtration. And if still the trab is failing, you can resort to needling also with this procedure. For the future, we are working either to make a wick which is completely biodegradable or a combination of biodegradable and non-biodegradable to give the long-lasting effect. I think I should stop there because I'm not able to share the
Yeah, I think freeze हो गया है, Prashant.
Yeah, you have to.
Is the presentation over or some slides are still remaining?
No, I am almost over. Nothing much.
Okay, I think I don't know. I think Harsh will comment upon it. A lot of different steps what we normally don't see.
Dr. Roop, can you stop sharing your hand? Okay.
Yeah, that's what I'm trying to do.
So right from that wick se leke and speculum and so many innovations have been described. I would like Harsh or anybody else to comment on this. Harsh.
Absolutely wonderful, bhai. Matlab, I didn't realize that. I thought Prakhyat was the man who was doing all the stuff. So it seems that it is actually in the genes. So Roop has been devising so many new things. So that is absolutely wonderful, I think. My only little concern is that most of the prominent people all over and the big institutions have given up doing collagen surgery. And like Tanuj used to do huge number of collagens and he's totally stopped it, saying that it doesn't work in his hands. And the fibrosis is the internal opening is usually not the problem. It is the fibrotic part, the subconjunctivally and subtenons, which is the one which is troublesome. And so yes, collagen over here should take care of that. And actually, certain things do work in a particular person's hand and they tend to evolve it accordingly. So I think everybody tries to do the trabeculectomy in their own little ways and modifying them in own little ways. But it is wonderful to see how he has really made some new things over there. So let other people comment, I think.
I think JKS is here. JKS, can you comment something about it? JKS Parihar?
I fully agree with Harsh on all these Ologen implants. I have done a lot, almost more than 100 odd I would have done with the valve as well with the trap. And the problem comes with this fibrosis and the blade is restricted with lot of vascularization and results are compromised. So somehow I'm not very fond of any collagen implants to be put. Second, we have to see these long-term results. And long-term results, if you are operating a patient at the age of 50 year or so, I consider the long-term results after 65 year. How this pressure control is going to be maintained. Second is a bleb leaking. Third is the possibilities of endophthalmitis when we are putting all these things. So these are the things which one must has to look into it. Regarding speculum, it's a wonderful. I have been using a plate speculum for a decade or so, and it gives you a excellent control. And for trap, I had I think from 2007 onwards, I had never used any 80 Vicryl or any brittle suture for all these procedures. So the speculum really does wonder. Plate haptics, these plate retractors are very good. So this is good thing we have to follow it. And regarding these wigs, and every new things has a challenges, every new things has a criticism. It's only the depends upon how do you enjoy and how the patient is enjoying. If he is happy and the patients are happy, we all should be very happy. That is my take on it.
Can I share the post-operative images?
One thing, Roop, a couple of questions have come up. One
Yes.
JKS has already said.
Can I share the post-op images?
Yeah.
My screen is visible?
Yes.
So this is 3 weeks post-surgery. You can see the blab and the wick inside. This is 6 weeks post-surgery. This is 9 months post-surgery. This is 1 year post-surgery. This is 15 months post-surgery. You can still see the part of the wick there. And I have follow-up for more than 4 years. This study, I have 50 patients, but otherwise I have been doing it for last 4 years, and I have post-op pictures of patients who have done well for more than 4 years. As you see the OCT, this is the normal angle, the top one. This is the wick. And as you can see, the fluid in the subtenon space, there cannot be a better proof than this. If you see the horizontal section of the OCT, you can again see the filtration. And the best part is that the blab is never thin walled. It always has a good thick walled blab. So that's what I am saying, that you can do it. If you have a thicker wick, it would work. More filtration would be there than of a thinner wick. If you do the releasable part, you remove this constriction and the flow would increase. So you remove the releasable suture and you would immediately see the height of the blab rising. As soon as the suture is removed, you would see that the blab height increases. See.
Wonderful, Roop. हमें तो सिर्फ कैटेट से दिखाना भी.
If it still needs needling, then it can be easily done. While doing the needling, you would see the blab forming. See, we started with almost a flat blab. Now it is.
I think it's frozen again.
So basically, we can change the porosity of the material for the future. We can use non-biodegradable matter, or we can have combination of both. So basically, my purpose is to evolve a safe, simple, and predictable and effective glaucoma management option that every general ophthalmologist can venture to do. Thank you all.
अरे ग्लूकोमा सर्जन क्या करेंगे? तो in any case there are a lot of questions. रूप दो तीन आपसे पूछ लेते हैं.
Yes, sir.
First is that I think JK has asked whether this wick can act as a nidus for infection. Have you seen?
I don't know how many, but I have never seen any infection in this. The only thing that can happen is that sometimes there is a black discoloration of the wick. So that area of the blab looks slightly blackish.
Okay.
But that is hardly of any consequence to the patient because it is always under the upper lid. But I have never encountered any infection till date.
Okay, the thing is that this video of Dr. Roop is available on YouTube and link is given in the chat box, or I think we will write it people who can view later on also. And the other question a lot of people want to know is about the where do you get this collagen?
Sir, this is collagen is freely available. What I do is I fashion it to my needs. Like I told you, I make it with the free hand. So by the time whenever I am using MMC, by the time the effect of MMC 2 minutes I have to give, I fashion this wick on the table itself.
Excellent. I think any other comment by any of our experts? Otherwise, Prakhyat,
Dr. Roop, if you can stop sharing your screen.
Yeah, I have stopped sharing.
Must congratulate you, Roop. Most of us knew you that you are a cataract man, but here is a challenge for glaucoma.
Yes, wonderful job done.
Yeah. If Harsh can say this, तो बहुत बढ़िया.
अब सारे different case वही भेज देंगे.
Can you please?
I have done Prakhyat, but it is not happening.
चलो हो जाएगा.
Okay, so after this, we now will move on to the quiz.
Long-awaited quiz.
If I can still not share my screen, if the admin can remove Dr. Roop from the program because his screen has hung, so he won't be able to do that.
Sunil, can you do that? Kuldeep?
Yes, sir. 2 minutes.
Can you please, because Roop ने press तो किया, but वो हो नहीं रहा close.
Yes, sir.
Yeah.
Yeah.
Okay.
Yes, Prakhyat.
So we'll dive in right to the quiz. We have the rules of the quiz are very simple. We have 10 questions with one single answer correct. and I'm going to display the question for 40 seconds. And you have to write your answer in the Zoom chat box, and you don't have to post it right away. You are required to post all your answers to the 10 questions together at the end of the quiz within 20 seconds of me completing the slideshow. So you write all your answers in this sequence, just as I have shown. If you choose not to answer a question, don't leave a blank space. Write zero or a dash or hyphen in that place so that your frame of the answer is not shifted. So suppose your responses are as follows. You write them sequentially without giving any spaces, and in place of those questions which you choose not to answer, write a zero or a dash or a hyphen. And then at the end of this session, we will compile the maximum answers correct. So the person who has the maximum answers correct wins. And if there are a couple of them, then we'll also rate them according to who responded first. I guess everybody
can participate, except the root family. Everybody else can participate from the panelists also.
So I'll start the quiz now.
Plus, Prakhyat, you should also tell that all this, quiz, there are prizes. There are prizes for that, sponsored by CIPLA.
Yes. So yeah. So if you want to win the prizes, now's the chance. So I'm going to set my timer and we'll have the first question. According to Ashenoff's try-soft shell technique, for optimal use of OVD properties, which of the following is the correct labeling of X, Y, and Z as shown in the diagram? The options are given. I'll not read them to not confuse anybody. Everybody can read them and post and keep writing them in your chat box. Post them at the end of the session. Last 5 seconds. Okay, so the next question is slow motion phaco for posterior polar cataract minimizes turbulence in the AC, thus protecting the compromised posterior capsule from sudden giveaway. Which of the following is not an adjustment mandatory for slow motion phaco? Decreased bottle height or irrigation pressure, decreased rate of aspiration or flow rate, decreased phaco power, or all of these are essential components? Moving to the next question, false about plaque brachytherapy using iodine 125 plaque. It is a beta emitter, more effective than ruthenium for thicker tumors. It is used in the landmark COMS study. Or D, it has more penetration than ruthenium and causes lesser choroidal atrophy. False statement. Okay, so time's up. To the next question. Very interesting. A 28-year-old male farmer developed a corneal ulcer and started on topical natamycin and oral voriconazole for a clinical diagnosis of fungal keratitis. The patient presents 4 days after initiation of therapy with no relief in symptoms and shows a relatively fulminant progression as shown in picture A. The culture of corneal scraping reveals no growth on the SDA, and picture B of the blood agar culture is shown. Your provisional diagnosis would be A. Neisseria or gram-negative bacteria, B. Pythium keratitis, C. Demataceous fungal keratitis, or D. Atypical mycobacteria. Moving on to the next question. A 40-year-old man with recent history of road traffic accident complains of blindness in the left half of his visual field. However, he recently noticed that he could see fast moving vehicles even on the left half of the field while traveling in a bus. The Humphrey visual static fields reveal left homonymous hemianopia. Considering that all these findings are accurate, what would be the most likely not be the site of injury? So, what site could not be the site of this injury if the patient has homonymous hemianopia on static fields, but he's saying that he can see fast moving vehicles even on that site? Moving on, a 50-year-old lady presents with diminution of vision in both eyes. The fundus picture is given here, and she has a systemic history positive for rheumatoid arthritis, poorly controlled hypertension, and nephropathy. Which of the following is likely? Oguchi's disease, Stargardt's disease, retinitis pigmentosa, or chloroquine toxicity? 50-year-old lady positive for rheumatoid arthritis and has poorly controlled hypertension and nephropathy. An 80-year-old man following up for neovascular AMD treated 4 years back, he continues to have good vision. However, fundus findings on this visit show multiple choroidal nevi, which were never seen before. He reports a lack of appetite, weight loss, and weakness for the past 6 months. His brother had died of an unknown cancer. That is a positive family history for cancer. Your diagnosis would be seeing these fundus pictures showing multiple choroidal nevi. What would be your diagnosis? Cancer-associated retinopathy, melanoma-associated retinopathy, B-dump, or choroidal metastasis. So we have a lot of mixed bag of questions from different subspecialties. Moving on, a 60-year-old man got right eye cataract surgery done with good gain of vision. On post-operative day 1, he had uncorrected vision of 6/6. 7 days later, he presents with an uncorrected distance vision of 4/60. So in 1 week, the vision goes from 6/6 to 4/60. The fundus picture and FFA have been shown. What is the likely cause? Ischemic CRVO, a combination of CRAO and CRVO, an exacerbation of a pre-existing retinochoroiditis, or a surgical procedure related adverse event. Ninth question. All of the following lenses promise an extended depth of focus as compared to the aspheric monofocal IOLs. All of them function on the same principle to provide the extended depth, except. So which of the following has a different principle? Vivity, Ihans, Magnificent, or IC8? Simple question for anterior segment people.
लैंडलाइन पे अपॉइंटमेंट फिक्स कराया करो, पहले 7 बजे से पहले होता है.
Okay, so the 10th question, the last question. A patient underwent femtosecond LASIK on post-operative day 7th visit. He was 6/6 in both eyes with mild dry eye symptoms. The patient presented 3 weeks later with a complaint of acute onset pain and photophobia. On examination, his vision remained 6/6 in both eyes. IOP was normal in both eyes. White eye with no inflammation in the interface or the AC. What would be the best step in management? Can everyone else please mute their mic? Okay, so last 20 seconds, you can please post your answers in the chat box.
Prakhyat, बहुत participation, lot of participation is there.
Okay, last 5 seconds remaining. Please post your answers.
So how much time will you take to analyze all this, Dhruv?
We'll have the last talk by our dietitian, and then I'll compile the results and we'll discuss the answers after the talk. So I'll now ask Dr. Romi Singh to introduce our dietitian, Ms. Rachna Agarwal, who would be talking to us about food to fight COVID-19. Over to you, Dr. Romi.
Hello, everybody. Once again, not taking much time. I'm introducing dietitian Rachna Agarwal. She's a clinical nutritionist and dietitian working as chief dietitian at Diet Coach. She has work experience of more than 25 years. She's regularly being in publication, magazines, and blogs. She has taught nutrition and macrobiology to AIMH and JIST Agra to many students. She's a regular speaker at talk shows for doctors, NGOs, and social events. She has held a workshop for Abbott Healthcare with pediatricia. She's going to address the nutrition needs of ophthalmologists in Corona times, considering their regular exposure to the patients and the long hours of work schedule. Now over to Rachna Agrawal.
Good evening, everybody. I hope I'm audible to all.
Yes, you're audible.
Okay. Thank you so much for inviting me today here. I would especially want to thank Dr. Mahipal Sachdev and Dr. Lalit Verma for giving me this opportunity. And today I would be discussing food during COVID times. So I will just share my screen. So food to fight COVID. When we are talking about food, we are talking for good health and nutrition and a better immunity so that we are able to find this deadly infection. But before I start talking about food, I would like to make it clear there are many other things that go along with food to get a better healthy body. So in short, I would like to just discuss it's about exercise, sleep, mindset, daily activities. These points I especially kept in mind for these doctors because I know you have a very busy routine. Sometimes your sleep is disturbed due to some emergency cases. You do not get time to exercise. And sometimes your daily activity is more of sitting on the OPD and you don't get to do more of moving about. So it's very important to make a balance of all these things to avail the health benefits of nutrition. Only a healthy nutritional diet will not help you alone to achieve a better healthy body. Secondly, I would also like to focus this point that health is not about losing weight. It is about gaining life. So many times the patients that come loss and weight gain will ultimately come. So you have to be sure that you're working for better nutrition and better health, not just valuing yourself on the weighing scale. This is a basic balanced diet ratio, which we should follow. I will not discuss it in detail as the audience is all doctors, and I'm sure you must have read and learned a lot about nutrition. But the only thing that I would like to focus upon is please make sure that 40% of our diet should contain of fruits and vegetables, and which we normally don't. If you compare, if I see an average plate of an average person, what I see with one roti, one person is eating half katori sabzi or half katori dal. So in that way, if you compare the ratio, you will realize that we are eating more cereals, more fiber-rich carbohydrates in comparison to fruits and vegetables, which are much higher on minerals, vitamins, and fiber, which are very, very important. Not discussing the balanced diet in detail, as doctors are all aware, I will talk about all the nutritional mistake we often make. And in this, I have made these mistakes which I assume that doctors can often make. My first thing is skip the supplements. Why I kept this slide first was, as doctors or as health workers, we are more under the influence of supplements, we are more aware of them, and we are reading more of them. So as a result, sometimes what happens, we tend to take an easy way out and we start eating these supplements more than they are required. Interestingly, we did a very good survey at PGI Chandigarh, where I did my internship, and we took the nutritional status of some children coming from a very poor background, basically children of laborers, and we took the nutritional profile of some children who were from the higher middle class, who were eating a lot of supplements and very so-called healthy food. But surprisingly, the difference in the nutritional profile was that the children coming from the lower middle class or the laborers' children were much higher on nutrition. They were not malnourished and they were not lacking most of the nutrients, as contrary to the other children who were coming from the well-fed families. So you have to understand that supplements are only in the case of severe infection or a surgery pre or post-operative and should not be eaten on a regular basis. They can be very harsh on the liver and the kidney, and in the long run can cause a lot of medical issues. Don't skip the meals, especially breakfast. I'm sure you have heard about this n number of times, but this goes very, very important for all professionals, especially doctors. You have long hours of clinic, long hours of working, and you're not aware when the next meal will be available to you. You're in your OPD and you don't know that if you'll be able to wind up timely for lunch. So the best thing is start your day with a heavy breakfast. I'm emphasizing again and again on heavy because normally what I see, people who are very who want to be very healthy, they opt for a very light breakfast, something like cereal and milk, poha, upma, something which is very light and very easily digestible. So what happens, it is digested in a matter of 1 or 2 hours, and once the time you have started working, your body is already starving of nutrients and energy. So it is very, very important that the first meal for us, the breakfast, should be heavy. By heavy, I do not mean fried or fatty foods, but it should have a lot of protein and it should be a complete meal. I would like to specify things which we have to avoid in breakfast, which are very highly rated. Cereals, breads, low-fat butter or snacks, juices, vegetable smoothies, and ready-made snacks. Discussing all of them in short, cereals are good, okay for people who are not able to cook or who sometimes don't have a time, but they are processed and they are loaded with a lot of chemicals, salt, and sometimes hidden sugars as well. So a fresh dalia is any day better than a ready-made muesli. Bread, a highly overrated food. It is even wheat bread or brown bread or multigrain bread has a major chunk of white refined bread, maida in it, and it has a lot of salt, sugar, stabilizers, and a lot of chemicals. So any day, anybody who's suffering from any kind of constipation or indigestion, I challenge you, you do not eat bread for 15 days and you will see a remarkable difference in your health condition. Low fat butter, which is very commonly, it is publicized everywhere, and it's sadly, most of my clients are eating this, thinking it's a low cholesterol butter. But I'm sure you all must be knowing that it is very high on trans fat, and any kind of butter, low fat or high fat, all have the same calories. So the best it would be not to have any kind of processed butter, even the yellow butter that is available in the market, and homemade white butter is the best. Juices, as you know, are very high in sugar, and always I advise to eat fruits and avoid juices. This is a very American trend where we started having juices with breakfast. Anyways, we should never combine fruit or fruit juices with a main meal, because the time period to digest a fruit is much less in comparison to something we are eating of protein. And when we combine both the things in one meal, the fruit juices tend to rot and cause us acidity. So it's very important never to eat your fruits, though juices I'm not advising as well, but anyone who is still having a juice, never to have it with the meals. Vegetable smoothies, very, very high rated and very much in fashion. I strongly stand against them. And I had even written an article for this in Health and Nutrition magazine. Why? Because vegetables are a little difficult to digest, and having them raw, especially in the form of smoothies, can be very, very tough on our digestive tract. They could lead to a lot of infection if they are uncooked. They could be very healthy. And sometimes a deadly combination of milk, curd, vegetable, and nuts and seeds could be a very wrong combination according to the Ayurveda, and it can cause a lot of disturbance and flatulence. Ready-made snacks, especially the low-calorie and baked snacks, are all a marketing gimmick. And most of them, a lot of them are fried and then baked, and they mention only baked. So anyways, fresh home-cooked food is the best. So please don't get lured into all these snacks. Why I mentioned this is because, again, short of time, everybody working, we tend to keep this in our clinic. But always we can opt, like this season, I would say, you could go in for a boiled corn, you could go in for a boiled egg, something which is fresh and it is not so difficult to be available. We have to include protein in our diet, but in a balanced form. I normally have a very contrary experience regarding protein with my clients. Either we go for a very low protein diet or a very high protein diet. The normal RD, as you all must be knowing, is 1 gram per body weight, but which is very difficult to achieve. So the best is to go in for a moderate protein diet, which you can easily digest. Non-vegetarians usually don't have an issue with the protein intake. It's the vegetarians, especially Indians, because we have a majority of vegetarians in India where we get a problem. So here I've just mentioned few of the very good sources of vegetarian proteins, that is lentil, milk products, soya bean, nuts and seeds. But along with that, we need to know that all leafy vegetables and all of other vegetables have certain amount of protein. And if we take a balanced diet, we will definitely be able to complete our protein intake. But when we talk of protein intake, we cannot forget the digestion of protein. Usually what happens, somebody all of a sudden starts thinking of joining a gym or wants to come to a weight loss or a weight gain therapy. The first thing they do, either they increase their protein or decrease their protein. But we have to understand that the digestion of protein is very, very complicated. This is the most complicated nutrient that we eat in our body. And this is the diagram which clearly shows that the amount of enzymes and acids that we need in our body to digest it. So in case at a moment you're eating a diet which only has about 20 to 25 grams of protein, and you decided to join a gym the next day, and all of a sudden you start thinking of increasing the protein to 60 to 70 grams of protein, your body will not be able to assimilate. The increase of the protein has to be gradual. You have to make sure that when you have increased your protein, you're not getting acidic. Make sure your uric acid is not going high, and you're not getting too much flatulence. Sometimes when we have too much of protein, we get foully flatulence, which is a very good indication to know that we are eating more protein that we need to digest. So it's very important. Protein is important, but to digest that protein is very, very important. There are many small methods where digestion of protein becomes better. For example, somebody who's not being able to digest pulses can have it in the form of sprouts. Fermentation helps to pre-digest the protein, and it's easily assimilated in our body. Avoid all the fashion foods. I call them fashion foods because they are marketed by the food industry. And as you know, the food industry has probably tripled of the profits, especially in this COVID time. They have really made a lot of profit. And the way they advertise is कि आप ये fashion food खाइए, आपकी immunity इतनी boost कर जाएगी, आपको corona से कुछ नहीं होगा. Even Baba Ramdev didn't stop from doing that. So it's very, very important why we have to stay away, because we need to know why we need to stay away from these fashion foods. To start with, first is olive oil. I'm sure the majority of you must be using olive oil in your house, right? And the reason, because we all think it's healthy. So I'm not denying the fact that olive oil is healthy, but it is a monosaturated oil. And the Indian version of this oil is mustard oil. Both of them have same chemical properties, but the difference is olives are not being grown in India. The oil is not being manufactured in India. So by the time the oil is reaching us, it is probably very stale. We are not very sure of the date of processing and the date when it's back and it is reaching us. So why spend so much on something when we have a cheaper, healthier, fresher version in the form of mustard oil? People who find black mustard oil little pungent can opt for yellow mustard oil, and trust me, it has a very, very good flavor aroma, and even the kids will enjoy it. Brown or multigrain breads, I did mention. A lot of people eat specially breads thinking they are healthier, but trust me, rotis, home cooked fresh rotis or even rice are much better than multigrain breads. Here, I would also like to mention one thing, as most of you are dealing with a lot of diabetics. And I'm sure a lot of doctors, the first thing that they do is they restrict the diabetic patient with rice. I hope you all agree with that. But with my experience of so many years, and I'm dealing with a lot of diabetics, I have come to this conclusion that brown rice or whole, the brown rice gives much better results with even patients who are on insulin. So if you're looking for a cereal, brown rice is much easily more digestible in compared to a bread or a multigrain roti also. Gluten, I have seen, causes more problem in sugar levels in comparison to rice. So I put most of my diabetic patients on rice and I get very good results with that. High fiber cookies, again, highly overrated. They are very high on calorie. One basic cookie, I'm not even talking of a fancy cookie, has 40 to 50 calories, which is equivalent to a chapati. So if you're eating 2 cookies with your cup of tea, it's better that you could have eaten a roti extra, which would have given you more nutrition. Fortified cereals or oils, again, full of chemicals. When we're talking of oils, I always advise cold press oils, which are easily available these days. And it's best to stay away from refined oils because they are full of chemicals and basically they are dead oils. The processing, the way they are processed, like rice bran oil or these oils, the processing is so, firstly, it is done on a very high temperature and a lot of chemicals are used. So in the end result, what we are getting, that oil is actually a dead oil with almost zero nutrition. And on the part of nutrition, they are fortified again with artificial chemicals. So it's best to eat something which is easily extracted. Low fat butter, I have already mentioned. Immunity booster medicines, they are nothing like immunity booster medicines. Basically, it's just healthy living, healthy eating, which will boost your immunity. So please do not come into these gimmicks. Antioxidant rich drinks, especially like green tea and green coffee. All these drinks do have a certain amount of antioxidants, but they are highly overrated. And we do not forcibly need to include them in our diet. All types of tea and coffee are almost the same. Only when we have a tea or coffee with milk, the calorie content of that tea and coffee becomes more, and it's sometimes difficult to digest. So firstly, limit your intake of tea and coffee. And this is especially for doctors because long hours of OPD, we tend to have a lot of drinks to keep ourselves alert. So for this, I would like to suggest you could have hot water infused with various spices. Like you could take a hot cup of soft water, hot cup of elaichi water. Trust me, we've started doing this in our OPD and even for the clients as well as the doctors, and they all are very happy with the results. You save on to a lot of calories, you don't tend to get acidic, and it really helps to improve your digestion. Protein powder, highly overrated and marketed because a lot of monetary benefits to the people who are selling it. I strongly stand against it. Only in the case, it is only advised for patients post-operative who are highly malnourished and who need that nutrition for some time. So only for them I would advise, but not on a regular basis. And protein powders are definitely very difficult to digest, and they should not be randomly added to the diet like that. Low fat or baked snacks, I have discussed earlier. So the thing is that healthy doctors will give us a healthy nation. It is very important that doctors take care of themselves. They are contributing so much towards our society. It's only because of the doctors we are able to fight this COVID pandemic. So if the doctors are healthy, they can take care of us. So it's very important for doctors to schedule their day, plan their meals in advance, because once they've reached the OPD, once they've reached the hospital, they possibly can't think of planning their next meal. So it's very advisable, if you are very, very busy, make a weekly plan, give it to your house help or your spouse, whoever is helping you with the cooking, so that you're also very sure, and try that the meal reaches timely to you. Make sure that you're taking enough sleep, proper hydration in your clinic, and very, very important, do some kind of exercise, which is very, very important. Thank you. I have kept my slides very short because I was told that I should complete it in 5 to 6 minutes. And anybody with any questions, I would like to answer that.
Thank you, Dr. Rachna, for that lucid talk centric to the health of the healthcare workers. If anybody has any questions.
यार प्रख्यात मतलब रचना जी, you told what not to eat. Can you just tell us, क्योंकि ब्रेकफास्ट में आपने सब कुछ ही काट दिया, तो खाना क्या है ये बता दो जरा.
आपके लिए तो मैं सबसे अच्छा कहूंगी, बेस्ट ऑप्शंस में है अगर हम खा सके रोटी सब्जी. I know some people think कि oh it's too difficult to have, but a nice
every day you can't have
stuffed roti, a roti sabzi.
How's idli dosa and all that?
Oh, idli dosa is very nice. Fermented food is very nice. In North India, I do not advise too much, because when I advise idli dosa, they'll end up making either that ready-made gits ka idli dosa, or they are making it out of suji. Again, suji, I do not advise. It's a refined food and it's very acidic. So if you're able to make the fermented rice idli or dosa along with dal and coconut chutney, then it's a very good meal, definitely. The recent study that we have done, coconut chutney really helps to digest idli and dosa. So always try and combine that thing, and along with sambar. Sambar would be advised for the protein content.
Coconut chutney में cholesterol तो नहीं ज़्यादा होता? Coconut chutney
it has healthy cholesterol. See, we have to take 20 to 25% of calories have to come from fat. So we have to take it from healthy options. That is very important.
So olive oil is to be thrown out, and mustard
definitely, definitely. आप ये करके देख लीजिएगा, you will find a lot of difference.
ये weight बढ़ाने के लिए क्या है?
Weight बढ़ाने के लिए, again it has to be protein and exercise. I'll tell you what I did. I have an online portal जिसमें मैं online diets देती हूँ. So we had 2 patients. One was for weight increase and one was for weight loss. So my assistant, I planned the diet, which were very similar because coincidentally their weight and height and all were matching too much. So she was really amused that, ma'am, one is for weight loss and one is for weight gain, और आप similar diet भेज रहे हो. So I told her, just wait and watch after 10 days. And that is exactly what happened. The person who wanted to lose weight lost 1 kg, and who wanted to gain gained only half a kg, because weight gain is more difficult than weight loss. Because your metabolic rate is so high, people who are naturally thin, so it gets more difficult. But with the same diet, with 2 patients, I got weight gain for one person and weight loss for the other person.
Harsh and me can apply together.
Yes, together. Please send us a chart.
I will definitely. Anybody is looking for a diet chart, I have shared my email ID. You can send me. I'll send you a form. You can fill it, and I'll be most happy to plan a diet for you. But when we are talking of diet, I really want to mention another thing is that when we're talking about weight, we have to understand our genetic conditions. See, some doctors, some professionals even say that genetic conditions are an excuse. But believe me, I get children from the same family, born to the same parents, and one child is underweight and one child is overweight. And the age gap is usually between 2 to 3 years, and they're eating from the same kitchen and probably following the same activity. But because they have inherited different genes from different parents, so that is the difference. So if we are a little obese, so we can only play with about 20% of your weight. So if you're 80 kgs, don't target to come down to 40. Be realistic. You cannot change the overall look. So we should try and targeting to lose gain or lose 20%. But trust me, weight gain is much more difficult than weight loss.
But very good talk and very practical points you have given.
Thank you so much.
And saved a lot of money also.
Yes, it's very, very important, because this thing that health is expensive, we really have to fight against it, because health can be really, really simple. If you compare the nutritional profile of the cheapest vegetable available at our vendors, like agar aap log, I don't know if you get it in your city, guar ki fali ek vegetable hoti hai, which is probably 1/4 the price of any other vegetable. Agar hum French beans वगैरह से compare करें, आप उसका nutritional profile देखेंगे, it is at least 50 times more. The mineral content of गुआर की फली compared to French beans, and price range में वो इतनी कम है, और nutritional उसमें वो कितनी ज़्यादा है. Like चौलाई का साग, if you compare it with kale, People normally will not eat it, but agar aap uska dekhenge mineral content, uska calcium content, it's so much higher compared to kale and all.
Very good.
Ma'am, if I may ask, what's your opinion on intermittent fasting?
Oh, I'm so glad you've asked this question. This passion has really come up in a big way. See, fasting was a part of our ancestral system of Ayurveda, and we strongly used to follow. But we have to understand in the modern times, our lifestyle is very, very tough and rough. We don't have a peaceful lifestyle, and we are always on that move. In that case, fasting too much, according to me, is really, really bad. Fasting was done by saints and priests who were meditating, not moving. They were just sitting at one place and they were very calm. So they were not burning calories. So it worked well for them. So I only advise fasting once a week, but definitely this new trend of intermittent fasting, I do not advise. I believe in the long run, it will increase your cholesterol. I have got a lot of patients who've been following intermittent fasting and they have increased their cholesterol level. And sometimes it even affects the uric acid level and acidity as well. Because I know a lot of clients who are very addicted to morning tea. तो क्या होता है, fasting तो कर लेते हैं पर खाली पेट सुबह चाय 2-3 कप पी लेते हैं, तो उससे और ज़्यादा acidity हो जाती है. तो I strongly do not support intermittent fasting. Fasting once a week is very good. That too if you are a little relaxed that day.
Thank you.
Prakash, you have to take over because a lot of questions I am sure will be there for.
I think we'll now just quickly run through the answers and know our winner, and then we'll have Dr. Mahipal for the concluding.
2 winners आपको बताने हैं, first and second, ठीक है?
So answers, the first was C, second C, third beta emitter is false, fourth pythium keratitis, a very upcoming problem, and I think everyone should be aware of it. We see it in our clinics now, so we should be aware of it. Then this question was on the redox phenomena, statokinetic dissociation, a rare thing, but interesting for neuro-ophthalmologists. Bullseye maculopathy, classic photograph. B-dump, which is a paraneoplastic syndrome, has to be distinguished from other manifestations in the retina. Then a problem that spelled the demise of intracameral vancomycin, HORF, and IC8 acufocus is actually a small aperture optics. Otherwise, the rest all were asphericity based enhanced depth of focus. And the last one was transient light sensitivity, a unique problem with femtosecond flaps for LASIK. So our winner is Dr. Tulika with 7 answers correct. And the second is actually Dr. Lalit Verma with 6 answers correct.
ये नहीं allowed है भाई.
ये क्या है, हमने तुक्के लगाए थे सारे.
So, and we have actually a lot of people with 5 correct, but so this is our congratulations, Dr. Tulika. And
Thank you very much.
Thanks a lot. I think we had a wonderful time. And let me share the screen once again for just thanking everybody. So this we all had, wonderful quiz. I enjoyed the best, and this talk was very, very good. Apart from the very nice cases, so I will request all the speakers to send the soft copies of their talks so that we can bring out in coffee times, as well as I've just started putting CCFS snippets. And this is posted to all the 25,000 eye surgeons across India. So this is one sample which I got from Telangana chapter, and Dr. Bilasha was kind enough to share this, and we sent all across. And you see, in one shot, in 24 hours, 9,450 people viewed this. So this will add to the visibility of CFS also. So Mahipal is there, so I'll ask him. Otherwise, I think Alka joined us. I saw that to give some concluding remarks.
Very good evening, everybody. Dr. Mahipal is a little busy with the advisory board, and you have me as a poor substitute for him.
No, not poor.
So I heard the later part of the talks, and if I may say so, the last talk was very interesting. But somehow, every day we hear of different theories. So one theory that somebody told me was that whatever grows on the plants, you can eat, but whatever is manufactured in the plants, you shouldn't. That kind of, covers all your breads and all. And I thought it was a very good thumb rule to follow. But
Definitely.
yes, I mean, you keep hearing every day conflicting stories. Sometimes they say ghee was not good, and then they say it's nice. And intermittent fasting was supposed to be a fad at one point of time. High protein diet was supposed to cause kidney damage. So you hear the pros and cons about everything. I think at the end of the day, whatever our dadi did, they say Indian food habits were very rich. So you should do what your grandparents did and eat anything that grows on the plant and nothing that is manufactured in the plants. So that's something I heard, and it is sticking to my mind. Anyways, coming to the Coffee with CFS session, it's been a great journey so far, and Dr. Lalit keeps doing something to it, changing the format and giving more people chance to present, and adding variety to the whole episode. And even as a non-ophthalmologist, I could feel that the effort that has gone into it, and it was a very enthusiastic talk. Everybody had well prepared it. So, and I think it's a very productive and a great way to stay connected in these COVID times. So all I have to say is thank you for the people who participated, and thank you for the listeners, and for making Coffee with CFS a great success and an event that we all look forward to. And thank you to Dr. Lalit for making this effort and carrying it for almost a couple of years now, if I'm not wrong. Yeah. So that's about it. And stay happy, stay healthy, stay connected. And I don't think I want to come in the way of you and your dinner.
Thank you so much for joining. And thanks to you.
No, it's been lovely.
And Ritika for all the help and cooperation.
Okay, just one moment. Dr. Maipal's just come in at the nick of the time to say a hello to everybody.
Oh, great. Thank you, Maipal.
Yeah. Thank you very much. Sorry, I had to step into another meeting. So I think great. We have had the second in the series of the 6 presentations, and as the attendance improves, I think Lalit, great job that we have opened it up to the other people, and I think let's keep up the momentum and the get on to still learning from all our colleagues across India. So thank you very much, everybody.
So thank you, Dr. Maipal, Dr. Alka, Ritika for all the help and cooperation. And I can't thank enough Dr. Tulika for helping me in each and every episode. And thanks are due to Kuldeep and his entire IT team for posting the links and helping every episode. And Sunil, I know they are working behind the scenes, but their help is unparalleled. And thanks to all the CFIs of the UP for yet another wonderful episode, I must say. I thought Telangana did a great job, but I think UP has given a tough challenge to them. And we look forward to the next episode that is in September last week. And the convener is Dr. Devashish Chakravarti, and he will be taking care of the East CFS, which includes West Bengal and Patna. And that will be another challenge for us. So I will request everybody to please. So I request everybody to please attend in large numbers so that as a family we all can contribute to this good educational exercise, and we progress also. Believe me, academics is one thing which makes you think differently, and you progress in day-to-day medicine also. So with this, we thank the entire CFS family, and also thanks CIPLA for their generous contribution for the episodes as well as for the prizes. Be safe, and thanks once again to everybody. Thank you.
Thank you.
Good night.
Thank you, Prakhyat, for excellent comparing. बढ़िया पीसी बन गया प्रख्यात.
Good
Thank
night,
you.
sir.